Hello everyone, I'm Dr. Francisco. I'm a nephrologist. I'm working also in NKF. Today I'm going to present to you this topic that is ECG tutorial. Okay. You probably have seen this movie, maybe some of you, or you movies like Memento or what is the Inception, yeah. So they are very good movies, but suddenly you're not sure if you understand what is going on or how, if the ending is like this or like that, etc. So see, but at the end of the day, you watch all the movie and you enjoy it, and then you end up with, probably learning something, and later you want to know more about the movie or you want to speculate things, etc. So see it like that, like we are living in a twilight or electrical world. Enjoy it. Don't worry about, you might not remember everything, that you might not understand everything at first glance. Also, we don't understand everything on ECG at first glance. We just need to study once in a while. So don't worry about that. But I will pass you the slides, a PDF with the slides later, so if you want to review this. Yeah. So, but just sit back, enjoy it. Whatever question, you let me know. Yeah. But I just need to tell you, if you have a weak heart, just maybe leave the room, because we are going to get very graphical, yeah? There is no single slide with words on it. It's a pure words, yeah? So let's discuss the basics. So the ECG basically is a trace of the electrical activity of the heart. It's plotting the electrical activity, the voltage of that electrical activity through time. As you can see in this plot, this is augmented, zoomed in from the ECG trace. Remember that the conventional speed of the trace is 25 millimeters per second, and one large square is like 0.2 seconds, and the normally the ECG is calibrated at 1 millivolt per 10 millimeters, so meaning like 2 large squares. So always check the speed, because if you change the speed of this or the voltage, you might see totally different things, and you might think the patient has got, let's say, if you reduce the speed of this, you might think that the patient has got a bradycardia when actually it's just a normal sinus rhythm. So always double check that indeed is calibrated to this voltage and to this. There is no wrong with the other ones, because sometimes you can see better the morphology. But if you are used to see this and suddenly don't realize that someone did it the other way, then you might misinterpret things. Yeah? Just a little tip on that. This is what you eventually see when the heart starts contracting and start activating. You see these curves, the P wave. There is also something called PR interval, that is this distance. Then there is the QRS complex. There is a Q wave that is a negative deflection, a positive deflection that is the R, and then a subsequent negative deflection that is the S wave, followed by what we call the ST segment, then a T wave. Sometimes there is other waves, but just typically that one. There is something we measure is the QT complex, that is from the beginning of the QRS till the end of the T wave. And something important is for you to know is the J point, that is the point where the QRS ends and the ST segment starts. Just we will go a little bit later on this. When the heart starts contracting and activating, we see a lot of electrical activity. Every region of the heart, you see all these regions, you're familiar with them, produces a curve of that electrical impulse by separate, yeah? But overall, all that together get this waves, complexes, and intervals that you normally see in the ECG. This is the summation of all those curves that I just showed you. But now, what is each curve? Where that each curve comes from? When you remember, the impulse starts in the sinoatrial node, so the sinus node, and then when this activates, because it's tiny, there is no visible activity. Then, number two, when there is atrial activation, when the atrium starts contracting, now you see the peak wave. Now, number three, this is the part of the PR segment, is the next. There is no deflection because it's the activation of the AV node that is also small and the bundle of His. But then in 4A, you start seeing how the ventricles start getting activated, and then in 4B you see how it's the PRS totally complete. It's the whole ventricle has depolarized and contracted. Then 5, when it's totally, then but still there is no deflection there. But now when this repolarized that is reactivated again for the next contraction, then you see the T wave. And occasionally there can be something called U wave, another little curve here, especially with hypokalemia. So that's where all these curves come from. You are very familiar with the placement of the leads. These are the precordial leads. You start in this intercordial space, and then you just move from B1 to B6. That's called the precordial because there's analyzing the electrical activity from the chest, in front of the heart. That's precordial. These are the chest leads again. What they see is the electrical activity from the heart going to the electrodes that you have just placed to those leads. So when the electrical activity goes to the electrode, it's a positive deflection. When the electrical activity is moving away, it's a negative deflection. So that's what you see. So this one, every lead gives you the image of the electrical activity. For example, this one, B6, let's say B6 compared to, let's say, B1, is a little bit different because in here, when the electrical activity is moving to this direction, probably is moving away from that one and vice versa. So you see that it's kind of different and opposite the image. So that's very important for you to know if you're interested in some of the basics. But it's important because many of the changes in MI, you have heard the term reciprocal changes, is the mirror image of the changes. That, for example, ST elevation can be a ST depression in another lead because of that, because it's the same stimulus, but seen in one direction to the other one and seen as going in the other direction by the other lead, These are the bipolar leads. You do the same to see the activity of the heart, but now you place a lead in the right arm, left arm, and in the electrode in the left foot. And then lead 1, see the impulse going from the right to the left. The lead 2, see the impulse going from the right to the left foot, right arm. And lead 3, see from the left arm to the left foot. When the heart contracts, when you're watching it from the precordial, you're watching how the electrical activity is. So now you're watching it from this side, and from that side. And there is the other augmented leads. That's why the A there, or unipolar leads, R from the right and left from the left, and F from the foot. But it's the same. So it's the same electrode, but now it's detecting the activity from the neutral position. You can say like more or less from the heart going towards that lead. Before it was, remember, the other lead was from left to the right, from left arm to right. Now, what you're watching in that one is what happens more or less from the heart or neutral position towards that electrode, and this one towards this electrode, like that, no? So you are getting a better picture, more it's still bidimensional, but you imagine like you're watching from here, from there, from that, the electrical activity, you get a better picture of the electrical activity of the heart. And all these generate what you know as a 12-lead ECG. So every one of those electrodes and leads I mentioned are recording this. So there are 12. Remember, I give you 6 precordial, 6 bipolar, and 3 bipolar and 3 unipolar. So that's why it's 12 lead, and you count them yourself. Yeah? This is an ECG. Many ECGs have 1 or 2 extra, no extra leads, but it's one of those leads, just extra picture here going through all the strip so that you can detect rhythm problems and heart rate simpler, you know. But these are the leads. Yeah. You have any question, just interrupt me. This is the normal ECG. It is very important that you familiarize with the normal ECG because, yes, you can go systematic through ECG readings, but also pattern recognition is very important. So you can more or less know how are the changes of, let's say, ventricular tachycardia, ventricular fibrillation. You familiarize with that image, or certain arrhythmias, etc. But you need to compare it to what is normal. No? So it's part of recognition compared with what is normal. So one of the most important things is you actually know what is normal. So, and then you can identify easily other patterns because you are combining, you know, both things, comparing normality with whatever you are watching there. And also help you, like if you don't know what are you facing, it's an MI, it's an arrhythmia, etc. At least you know that it's something abnormal, and then you can flag it to your superior, to the doctor, or to a specialist, etc. So learning how the normal ECG looks, it is very important. Excuse me. So, but obviously it takes a little bit of time, but it is crucial. So, and remember all those complexes and curves and, you know, waves, intervals are all these PQRS, but translate eventually into all these 12-lead ECG. And everyone, it looks a little bit different because what I told you is watching the heart from different perspectives. Yeah. We were going to talk a little bit about heart rate calculation. Probably now you use the oximeter or the BP monitor to tell you what is the heart rate, but sometimes it's good to confirm it here. Basically, when the rhythm seems regular, yeah, it's good to use this formula. There are ECGs that have this line. This is just the separating the leads, yeah? So don't confuse that this is electrical activity, but I know it can introduce some noise. This is not, yeah? This is one lead, there's another image of the lead, but it's the same beats. This beat is this beat, yeah? So when it's regular, the rhythm seems regular, you can use the formula 300 divided by the number of large squares, this is one large square, between the R's or the P's. You can either identify the P's and then measure how many are between this P and the other P, or between this R and this R. It's simpler to identify the R sometimes, you know. So when this R is exactly in the line, so it's very easy. So you count how many, 1, 2, 3, 4, correct? So the formula 300 divided by 4, 75, correct? So, but if the rhythm is not regular, it's irregular, it's the same ECG, but I'm just going to pretend that these lines that divide the leads are a QRL complex, yeah? So imagine that now there is one, there's another, third, fourth, this is just fake, yeah, just four, for you to understand. This is the whole strip, you imagine this is 2. If that happens, you multiply 6 by the number of QRL complexes in the entire strip. So in this case will be 12, so 6 times 12 is 72, yeah? If the rhythm is irregular. Calculation of the axis of the ECG is also important. I'm not going to discuss so much on this, but there is a formula, but these are the axes of the different axes of that can have the heart. There is the normal one, and the left axis deviation, right axis deviation, can be extreme axis deviation. But there is a rule of thumb that if the QRS complexes are positive in leads 1 and 2, it's a normal axis. If it's positive in 1 but negative in 2, left axis deviation. If this negative in 1 and positive in ABF, is a right axis deviation, and if it is negative in these two, it's extreme axis deviation. Yeah. So, but I will focus more on pattern identification, but it's important to always calculate the axis of the ECG. So, let's discuss sinus rhythm issues. Let's go straight to pathology. The sinus rhythm is defined by, well, it's a normal rhythm of the heart that has got a peak wave, is regular, has got a heart rate that is normal, 60 to 100. But also something important is that every peak wave is conducted, means that is followed by a QRS complex. So meaning that the peak wave contraction work and then lead to activation of the ventricle and also contracted. So that means that it's conducted. If you see a peak wave that doesn't have a QRS complex, so it's not a normal sinus rhythm, yeah? And I just showed you there the peak wave, yeah? In the asterisk. So this is a sinus arrhythmia. So this is not normal, not that they are normal, because many people who are normal just simply have it, because in some people when the people start expelling air, so during expiration, the heart rate drops and it's a little bit faster when it's inspiration. So that's why you can have, like, maybe the patient is on expiration here and then inspiration. So but it's a normal sinus rhythm. It's irregular, but it's a normal sinus rhythm, so that's why it is called sinus arrhythmia. Yeah. This is a sinus bradycardia. It's a normal sinus rhythm, but you can see if you do the formula, remember 300 divided by a number of squares. Now we use this P, will be 1, 2, 3, 4, 5, 6 squares till the next one. So 3 divided by 6 is 50. Yeah. So, and everything is okay, no? It's a normal morphology P wave followed by a QRS complex. Every single P is followed by QRS complex. Everything looks normal, so it's just simply a sinus bradycardia. Yeah. So this is sick sinus syndrome, especially people with heart problems. Sometimes the ischemia of the node doesn't work very well to transmit the impulse. So there is sinus pulses, and the patient can feel this, he can have syncope, etc. Or worse, they can be, for example, here, because there's no activity, so there is a sinus pulse. One part of the heart wants to take over, and there is a junctional escape beat. This looks like that. It's different from this QRS complex, yeah? This has got the morphology of the junction because it comes from the junction between the AV node and the atrial node. But as I told you, don't need to remember all this. Just understand it and enjoy it, and that's it, yeah? And then this, for example, this is sinus beat because it has got a peak wave and QRS, but this one is just no peak wave, just has got it could be a different morphology, but it's a morphology from the junction. Okay. This is sinus tachycardia, sinus rhythm, but faster. In this case, you apply the formula, the heart rate is 130. Just simple, yeah? Sinus pause is another pathology. Suddenly, there is a peak wave here, peak wave. Then suddenly there is no peak wave. A pause here of electrical activity, then another peak wave or complex. So something happened here. So, but there is no peak wave. So the sinus didn't trigger the impulse. And it's called sinus pause if you will imagine that there will be a expected P wave here, the next one there will be expected here. This pause is shorter than 2 expected normal P wave intervals. Well, if it is less than 2 pp's, this is 1 P, this is another P, this is the 2 P's. Yeah, so it helps you to identify that it's a sinus pause. But that's a little more too advanced. You don't need to remember. You remember very good all those details. But what you need to know, what is that? This is normal or not normal? It's not normal, no? And suddenly there is a gap there. Suddenly I can see a P. I don't know what is this. Maybe it's a block, but definitely it's something not normal. And the patient probably is bradycardic or symptomatic. So that's what matters, no? And then let someone, a specialist, to pin down with more ease. But if you can do it, obviously very good. The same just for principal teaching. I'm just telling you, for example, if there will be a sinoatrial block. So there is activation, but the impulse is blocked from the sinus to the atrium, and there is another pause. But for example, this pause occurs in a 3 to every third beat. Suddenly there is a pause. For example, here there is a P wave, then there is a P wave and no QRS. Yeah. So suddenly there is a pause, and this pause is less than 2 pp's. The next one has got also a 3 to 2. So every third beat there is a pause. There is no P wave there, but now this pause is exactly the length of 2 pp's. Yeah. So that's why it's called sinuatrial block type 2. But this, you might forget those things, doesn't matter, just understand, like in here there is a block in the impulse, so that's why there is no electrical activity, there is no contraction of the atrium, and then the ventricles, there is a pause, and then suddenly it kind of recovers, but it happens again. Yeah? There's another one, sinoatrial exit block. The pause is also 2 pp's intervals. So there is a P wave here. There's a P wave, but there is nothing here. Just some examples. This one is now the opposite. So now there is overactivation, a sinus node re-enter tachycardia. There are many tachycardias that the stimulus, instead of going always in this direction, suddenly it start coming back and then activates again the heart, and then it's another faster beat, etc. So, and because it comes back and comes back, it's called re-entrant. That can happen on the nose, can happen on the sinus. In this case, happens. Oops, what happened? Well, I turned it off. Okay. Happen on the node. And the AV node, so this one is happening on the sinus node. So you can see here there is the P wave, and it's a very fast activation. So in the QRS complex, then again and again and again and again. And this one also characterized by abrupt onset and fast offset. Yeah. But what you can see here, that the patient is tachycardic, and this one, it doesn't look quite normal. There is not like there is the P, there is no the PR length, and then the QRS. There's no gap here. No? So you might forget this is sinus or whatever tachycardia. You don't know, or you know that the patient is tachycardic, looks a bit normal, but something is not right. Yeah. Just now we're going to just discuss very briefly about tachycardia. So I told you I'm going to give you the notes, but you have seen probably similar plots that tachycardia can be regular or irregular, also can be divided narrow complex or wide complex, and depending on these characteristics, in this flow chart you can identify with more accuracy certain diagnosis, no? For example, tachycardia is regular and narrow, could be a sinus tachycardia, no? If it is regular and wide complex, could be a monomorphic VT, although there are other possibilities. Irregular, narrow complex could be atrial fibrillation, but is irregular and wide complex could be a polymorphic ventricular tachycardia, yeah? So you will have the slides. We are going to basically talk about or show you a sample of all of these, so that's why I'm not going to go one by one now, right? What is also important is that identify what is the relationship between the PAR and the QRS. So the QRS is regular, there are P waves or not, so what is the heart rate, and on the basis of that also you can pin down certain diagnoses, no? Typically, when the rate is very fast, atrial flutter, atrial tachycardia, is more plausible. A sinus tachycardia, probably the rate usually doesn't go that fast, etc. So all those little combination of these features can help you identify with more accuracy certain disease processes. Yeah. For example, in this case, if the QRS is regular, but let's say the rhythm is regularly irregular, then could be a wonder atrial pacemaker. I will show you what that means. But wandering means like walking here, walking there, etc. Atrial pacemaker is in the atrium. Pacemaker means that is the one leading the heartbeats. So meaning that sometimes one portion of the atrium is the one leading the heartbeat, and then the next time is the next portion of the atrium and things like that. So, but for example, in here, if it is irregular, could be still a sinus rhythm with the topics. You will know what is that. So go back later to this plot, and for you will enjoy them better. Bradycardia, the same. Something important is there are P waves. Maybe there is no P waves. Remember, we showed an example of 6 sinus rhythm, or could be atrial fibrillation that also doesn't have P waves. Or let's say that they have. Now, is it constant or not? Let's say if it's constant and the PR is fixed, could be a sinus bradycardia. If not, there might be some degrees of blocks, etc. But I told you I'm just going to show you examples so you will understand that better later. So let's go towards myocardial infarction. That is something very common and is something that we all are afraid of. Doctors, patients, relatives, everyone, no? Because what it means, no? It means losing functionality, losing maybe years of life, maybe even losing the life. Could be on the spot and things like that, no? The patient collapses, etc. So it's something that is important to identify because you can probably treat and diminish the damage and then the impact on the heart function for the future of the patient having the heart infarction, or prevent a lethal complication or any other sequelae, etc. No? So it's important to identify that, but what would be better even is try to improve all the diet, lifestyle, and treat comorbidities, so that people eventually doesn't develop a heart attack. No? But okay, let's just remember ECG normality is very important, especially for myocardial infarction, because you want to identify those ECG changes. No? So if you know what is normal, it doesn't matter that you know what type of myocardial infarction it is, but if you know that is not normal or a normal ECG doesn't look like that, you are already helping everyone. If you are more advanced and you can identify certain types of MI, so even much better. Yeah. For example, this one is a endocardial ischemia. There is ST depression. Yeah. Remember, this is the ST segment, and is depressed here. How you know it's depressed? It looks depressed, yeah. But you compare it to the PR, yeah. So in comparison to the PR, it should be kind of aligned. So if it is not aligned to the PR, and it's lower, so it's depressed, yeah. And this quite widespread. There is a bit of reciprocal changes here. Is the other side of the heart is seeing the opposite. So it's seeing, if it's seen from the other side, when it's a positive deflection here, and the other side, it will be a negative deflection. So if it's negative here, it's a depression here, in the other one will be elevation. Okay, then now for you to compare, simply just see this is B5, how normally B5 will look, you know. As I told you, the ST is in line with the PR, yeah? So these are the hallmarks of ST elevation MI. That is basically ST elevation. Remember, this is the J point. The J point is where, remember, where the QRS ends and the ST segment starts. Both the ST is elevated and the J point is elevated, yeah? So with that, it's more characteristic of an MI, and you can see here it's very elevated. If you compare to lead 2, what is lead 2 is this one, yeah? So you see how it normally looks, yeah? You see lead 3, and this one is ABF, yeah? What is ABF here, yeah? So it's important to know what is the location of MI. That's the next level, because sometimes can have different symptoms. There are also different approaches and different precautions. Typically, an anterior MI, there are changes, in this case, ST elevations in the precordial leads, or in most of them. Remember, V1 to V6. Anteroseptal is more focusing in V1 and V2, anteroapical in V3 and V4, anterolateral in V5 and V6, lateral in 1 and AVL, inferior in 2, 3 and ABF, and posterior in V7 to V9. You know what is this, V7 to V9? Who knows? Okay, don't worry, you will know. So let's just flash some examples. All of them will have elevations. What matters is just where those elevations occur. This one is an acute transmural, this anterior MI. You see most of the elevations are in the precordial, basically through P1 to P5. All of them is elevated. If you want, you just visually quickly go down and compare it to the normal ECG. This is an anterior septal apparent infarction. It's also acute. You can see in B1 and B2 and B3 mainly, and B1, and the reciprocal changes. You know, the ST depression happen in B5 and B6. Why? Because if it is an anterior septal, more or less is around. You're watching from here. It's happening here. So these leads are watching here, and B5 and B6 are already around here. So that's why it's almost see the opposite image, yeah, of the same activity. So that's why it's positive here, or elevated here, and depressed in that one, yeah. And this is anteroapical. So B3 and B4, you see the changes there. That's the elevations. Anterolateral, you know. In 1, you can see some ST elevations, B5 and B6, and ABL. The typical is 1 and ABL, whereas you can see in B5 and B6 because it's on the lateral side, no? Also watching the lateral side, and the anterior. Yeah, this is a lateral MI. 1 and ABL is very prominent with some reciprocal changes. Here, this one. This is an inferior MI. You can see, remember, the inferior leads is 2, 3, and AVF. So you see more prominent the changes, the still elevations there. And there is reciprocal changes in B2 and B3. Actually, if you see here, it's quite nice. If you will rotate the image horizontally and vertically, is almost the same image, yeah? So that's why it's just the same scene from different. It's just like seeing in the mirror, no? When you see in the mirror, life is on the right or things like that, so it's the same, no? This is an evolving inferior, posterior, lateral MI, so where changes on those positions. But there's also Q waves and ST elevations here. You can see the ST elevations. The Q waves not only occur in all MIs, but obviously you see Q waves and you know the person had an MI, so it might be just an OMI, but after an acute MI, they can start evolving and the Q waves start appearing. So for it's too small, but you can see here the ST elevation, and this Q, it looks a little more prominent and wide than normal. Let me see if I put the one for compare. So you really, for example, focusing here in 3, you can see 3, how is the Q? Basically there is almost no Q there. So that's why this one is a little bit wide and deep, so it's a Q wave, yeah? So chronic myocardial infarction, the same anatomy, just for those interested, if you want, is the same. Precordial leads, if you see changes there, it's an anterior, and accordingly, what I already mentioned for the acute, for the chronic, is the same, no? Depending where the leads show the changes is the position. Obviously, these sometimes don't correlate that well with what eventually you find, unfortunately, in an autopsy of the patient. Sometimes maybe the impact is a little more to one region, etc. But for clinical purposes, it is still quite useful. Yeah. So this is chronic anterior myocardial infarction. You see the Q wave. So this is B2. Look how B2 the Q looks. There's basically no Q there, no? Almost. Little Q wave, then an R, then an S. Suddenly, there is no R, basically just a Q, and there's no R. So that's why this is a Q wave. That's how the Q wave looks. So you see this, but remember everything, you are not sure, but that's why compare always to the normal. You can have a comparison to normal people, but also what it helps, comparison to all ECGs, no? So that's why always we ask, also show me the all ECG, no? Because maybe there is ECG when the patient, before the patient had an MI and things like that, you can identify the difference, yeah? This is a lateral one, so the same, the Q waves happening on the one that you can see lateral MI, no? Remember 1 and AVL. On inferior MI, number 2, 3, and AVF, you see the Q waves. Now, you might say, oh, this one looks already normal, but see how the Q looks in AVF. You know, it's quite tiny, yeah? Suddenly this one is more prominent, yeah? And this is a posterior MI. So, there will be supposedly probably Q waves in the posterior chamber, but these leads, unfortunately, don't see the posterior aspect of the heart. So to do that, you need to do something differently. But in here you can see that there's no ST elevations. You can say, oh, maybe there's ST depressions here, maybe some ischemia. That is true, could be ischemia, but what if actually this is not ischemia? What if this actually just reciprocal changes? And there is ST elevations in the posterior leads, that is B7 to B8, because there is a posterior MI. To identify that, what you need to do is just place the electrodes at the back. So now you will be, watching the heart from this position, and in these leads, that basically now you will see the Q waves, or if it's acute, you will see the ST elevations there. And what you saw before, it was indeed a reciprocal image of those changes, yeah? And because, for example, this one is actually probably a Q wave. What you will see in the posterior lead as a Q wave probably is this. This is B1, See how is the R in B1 is actually quite small, yeah? So this one looks like a R there, but probably is the reciprocal image of the Q wave that you will be seeing probably here, yeah? So I told you, this is more advanced. You might not remember all that, but you just understand the principles, and I told you, like those movies, just enjoy it, and then now, it's nice, yeah? So I hope the exam that they need to give you is not with those specificities, just the basics. Yeah? Okay, now let's talk about ventricular conduction defects. This is basically incomplete right bundle branch block, where you have heard those terms. So meaning the conduction through the bundle going through the ventricle is delayed for whatever reason, maybe a pathology, etc. Then the QRS are looking funny. The conduction is a little more difficult over there, so it takes longer time, so that's why it's a little bit prolonged, and it gets a funny shape, And then you start seeing sometimes a second R that is called R prime. And sometimes if it is too big, they call it in capital letters. No, if it is small, they call it in lowercase. Yeah. So those things, when you see this RSR prime, etc., most likely they are talking about one of these body measurements, which is the right one. There's another one, is a complete one. You can see in B1, there is the Rsr1 pattern. There's an R here, then the S, and then another R. Normally there's only one R, correct? And there is a wide S here, so this one looks quite wide. You see how the S normally looks, yeah? This is a complete left bundle branch block. This one is funny because, it's a little more prolonged. This R, like, it doesn't go all the way down and then goes up again. That's what we call it like rabbit R. They can be ST depressions, wide R's, but also there could be something like, it looks like a Q wave, but it's actually even wider than the Q waves you see on MI. And because it's not sure if it's a Q or an S, they just call it QS. So it's quite characteristic of left bundle branch block. Meaning the conduction is not going very nice through the area, through to the ventricles and along the ventricles, yeah? So this one also intraventricular conduction delay. There is abnormal QRS, is wider, but it doesn't resemble either an R or a left, yeah? So it just look dodgy. I'm sure they're not going to ask you the diagnosis. This intraventricular or left bundle branch, etc. Probably they will ask you something simpler, yeah? This is bilateral. Sometimes this one resembles a right bundle branch block, and this one resembles a left bundle branch block, and this one is a little bit normal or subnormal, yeah? This is intermittent bundle branch block. Suddenly there is a nice, and then suddenly there is one that looks like bundle branch block, then another one, and another one. Aberrant ventricular conduction. As you can see, this one looks too dodgy. It's quite wide. Suddenly there is this R, then S, another R, and this beat. There was the rate. happening like that, suddenly appears earlier. So, and the conduction doesn't look totally fine, yeah? Let's talk about some ST segment defects. They can be on a specific change that you're probably not sure what it is, but it doesn't look too normal. But one that is important is pericarditis, that you have ST elevations, but they are more widespread. Something more characteristic is the PR depressions. So it's depression here and ST elevation. And the ST elevation seems to be concave, so like going like that. And also there are no reciprocal changes, so this is suggestive of pericarditis, that the lot is in all the, or most of the leads, so in a way you don't know where is the MI, and it will be very difficult that suddenly all the arteries block, no? So that, and probably the symptoms, no? Maybe it has got a flu, some pleuritic chest pain. Remember, pleuritic is that gets worse when someone breathes. So indicating inflammation of the pericardium. This is how it evolves. There's some elevation, so the arterial normalization, then there's some T-wave inversions, and that goes back to normal. We already talked about this interventricular conduction delay or defects. We mentioned the right bundle branch block can cause also changes on the ST segment. As you can see here on left bundle branch block. Also the ST can invert and look abnormal. And aneurysm, like the fistulas, aneurysms also can happen in the heart. There is a myocardial infarction. The wall gets weakened and then can dilate. And after an MI, typically, if this persists for around 3 weeks and then still the elevations, and typically look quite round, quite convex. So it's probably an aneurysm, yeah, as you can see here. Also, other issues on the ST segment is the prolonged QT. We talk a little bit later more, but for example, in hypokalemia, hypocalcemia, short QT in hypercalcemia, peak T waves. You are very familiar with hyperkalemia, can cause peak T waves. Prominent U waves, or is the T, and then there is another wave there, is in hypokalemia. Also, left ventricular hypertrophy. There are very tall R waves here. Sometimes can be, you can see the difference. So typically it doesn't go that high, and it kind of go up the QRS and start going down in amplitude. But here it kind of goes up and then doesn't go down that fast or nicely. Yeah, sorry, the progression between B1 to B6. But sometimes can cause ST changes as well, like some people call it like ventricular strain, so like already struggling a little bit the ventricle. Yeah, as you can see, normally the T wave will be positive here. Yeah? AB blocks. If you want a break, you let me know. Are you okay? Yeah. No one has asked any question? Any question? Great. We already mentioned some blocks on the sinus node. Then remember the impulse goes then into the atrioventricular node, the AV node. So also that the impulse can be blocked there. So what is next? That will be the conduction to the ventricles. It will be also impaired, and is what is called the AV block. There are many degrees. The first degree AV block, that is very common, especially people with beta blockers. So you see that the PR is prolonged, it's more than one large square, the PR interval. And the patient might have tachycardia, they say bradycardia as well, yeah. The second degree AV block, or Mobis type 1 or waking back phenomenon, occurs when there is also a block in the conduction, defect in the conduction from the AV node downstream, and then the PR prolongs, then prolongs a little bit more, and suddenly there is no conduction. So there is a missing QRS here. So until it is not conducted. So it just prolongs a little bit more, and then suddenly there is nothing. The Mobis type 2 is suddenly there is nothing, but the PR interval is okay. So that is working here, is conducting fine, and suddenly there is no conduction. And this cycle repeats kind of in a regular fashion. So that's the type 2. This is an atrial flutter. The F lowercase is flutter. The capital is fibrillation. But has got block. Why is that block? Because there is atrial contraction, another atrial contraction, another atrial contraction. Then there is the QRS. Here there is atrial contraction, and then QRS. Here there is 2, and here there is 3. So the block here is 2 to 1. This one is blocked, so there is no conduction to the QRS, so that's why there's no QRS after this one. In this one is block, and then so there is a QRS, yeah? So that's what it means. This is third degree AV block, that is the worst, or also called complete heart block. There is what it is called AV or atrioventricular dissociation, or QRS dissociation, meaning that the contraction of the atrium and the ventricles are separate. So the atrium starts contracting on its own, and the ventricles also on its own, and at different rates. So as you can see, this line indicates the P wave. There's a P wave, P wave, P wave, P wave, P wave. But only there is a QRS, and this is a different rate, and there is no relationship. For example, this P wave here, there's no QRS there. This P wave, and there's a QRS here. So it's like they are acting separately, yeah? There is another case. You will see the P waves contracting differently. For this one, the escape rhythm. So now the ventricle needs to contract, no? So because there is no activation from the atrium to the ventricle, so a new pacemaker start working, coming from the ventricle is ventricular, so it's not so wide, because you in the heart still need to be, yeah, escape, because kind of the impulse needs to escape through there and start beating. Yeah. There is another one, but this one is a bit wider and a bit slower. This is a ventricular escape rhythm. The other one was ventricular. There was junctional, if it's from the junction between the atrium and the ventricles, and it's quite narrow. Then the ventricular, then the ventricular that is even wider. It's just simply that because there's no activation of ventricles by the atrium, or then the ventricles eventually to say, oh, so I need to start beating, and then one part of the ventricles start taking over the pacemaker role. Let's talk about ventricular arrhythmias. This is a ventricular premature beat. You can see this is the normal one, and then another one, and before the normal is expected, suddenly there is a beat that occurs earlier, is totally different, so it was called bizarre and wild, and alters the QRS interval. Suddenly you expect that the next beat after this will be around here, yeah? Suddenly it delays a little bit, because this one works like one. So occurs before, is created in another part of the heart, in this case the ventricles. That was called ventricular premature beat. When it happens, this premature ventricular beat, but doesn't alter the frequency of the normal QRS complex. Just is intercalated or interpolated. It's called like that. Yeah. So just for comparison, this one, remember, just appeared earlier than expected, but then delayed the next normal QRS. In this one, the expected QRS occurs at the same frequency, just different. Yeah? Then this one are what is called ventricular bigeminy. You probably have heard the term. There is another premature beat, and then a normal premature beat, normal, and just something like that. So occur in pairs. So that's why bigeminy. Yeah, when every third beat there is one premature ventricular beat, then it's called trigeminy. They can come two together, that is called couplets. We already commented on this, also come from the ventricles, this ventricular escape rhythm. Yeah. There is something called ventricular parasystole. But what it means is there is an independent ventricular rhythm. You can see here there is the rhythm, yeah, the normal one. Suddenly there is one beat here that is different, but then it comes again and then appears in regular intervals. So suddenly there is, yes, the normal is, but also there is, an independent. The ventricle is working and firing on its own at regular pace. Yeah. This is monomorphic ventricular tachycardia. You can see all the complex is quite wide. The heart rate is very fast. So you see, here is like 1.5 squares. So remember, it's 300 divided 1.5. So it's quite fast. And there is also AB dissociation. There are P waves present here. This is a P wave. Yeah. Here there is another P wave. So the ventricle is contracting on its own crazily. This is polymorphic ventricular tachycardia. It looks totally different. It looks very irregular, and the morphology is also varying. These are the fusion and capture beats. For example, I mentioned a little bit later, but the fusion beat, a normal QRS fusion with one of these escape beats, and then form a different one looking totally different, and a capture beat suddenly kind of a more normal beat start, they start capturing and start like trying to work normally. Yeah. This is ventricular flutter. There's atrial flutter. There's also ventricular flutter, but it looks more homogeneous, no? Also in a sawtooth pattern. But in this one, the difference to the, for example, monomorphic tachycardia is that there is no P waves. Yeah. To sag the points. The point. So basically, it's a kind of tachycardia with the axis is changing. So sometimes it points to one direction, sometimes it points downwards, and if it's changed, it's associated with QT and can lead into ventricular fibrillation. This is also tachycardia is accelerated ventricular rhythm. So you see, it's not normal QRS, comes from the ventricles, but it's not a wide one. This is ventricular fibrillation, so I don't need to put you the normal one. It simply looks how dodgy and different. So this patient, you think you can talk to this patient or not? Yes, it's already collapsed. So this patient needs to be what? What type of shock? Cardioverter or defibrillator? So the cardioversion is just try to align with the normal QRS to catch them and try to resynchronize the rhythm. But in fibrillation, everything just is very random and crazy, so it doesn't matter, and then you just try to bring this to normality. So chamber enlargement is also important. This is called the P mitral. The characteristic of left atrial enlargement. You can see the P has got 2 notches there. When it's right atrial enlargement, there is one big P. You see how big it is? That is suggestive. Left ventricular hypertrophy, we already mentioned a little bit, you know, like the R's are quite tall. Right ventricular hypertrophy seems to be that the R's start getting taller much earlier. You see, for example, in here, in big one, the R is very small, but here it's already being quite big. So it's because now the side, that is right side of the heart is bigger, and is mainly seen by these leads, you know, on the right. So that's why. Can be ventricular hypertrophy in both, so you find changes from both, yeah. Now let's move to supraventricular tachycardias. This is escape atrial beat. Remember the ventricular beats, but now the atrium also can suddenly have a contraction. In here you see the P wave, but here this P wave looks very, very funny because it is not the sign. It doesn't come from the sinus node. It comes from a part of the atrium. After a pause, you know, there was a long sinus pause here. Suddenly, this takes over, and then there is the escape beat. Yeah. It can be ectopic atrial beats. So the pacemaker is again in the atrium, and you see the P waves are totally different. No? It comes from the atrium, not generated the impulse in the node, and the atrium contract nicely. You can see the difference of how will be the P waves in two. Yeah, so it's different. Yeah? Atrial tachycardia. So there is tachycardia, and also the P waves is not like a normal P wave. No? It's a different shape. Can be also the same, but with block. So meaning that there is a funny P wave that doesn't look like normal, but sometimes it's conducted, sometimes it's not conducted. Yeah, here it doesn't have a QRS complex, so that's why there is some block on top of that. The wandering pacemaker, remember we talked, so like some parts of the atrium are sometimes working as pacemaker, then another part, etc. So that's why there are P waves with different morphologies, yeah? And also the rhythm is irregular, yeah? Multifocal atrial tachycardia. So there is tachycardia, the heart rate is high, but also the P waves, as you say, is varying in morphology as well. We mentioned an example of either premature beat. So, for example, normally will happen here, and expected here, but this beat appears earlier, the P wave appears earlier. It's a little bit funny in shape, and then it's conducted, yeah? So it's an early occurring complex, earlier than expected, probably was expected around here, yeah? Following the same regularity. So there is, and this is a block atrial premature beat. It's going to occur early, but there is no conduction. But you say, oh, where is it? This is the T wave, but suddenly this T wave looks totally different from the other T waves. It's because the P wave, the premature atrial beat, occur here. So the two electrical activities overlap and make this bigger. So when this one is repolarized, the other one was contracted, so now the deflection looks bigger. And But because there is no conduction, so that you say it is blocked, and because also there is a pause there. Yeah? This one is the same, but there is some aberration. So now the next complex is not like a normal-ish or normal. It looks wide and broad and funny shape. So it has got this conduction problem that's called aberration. Yeah, because normally when the heart contracts and when there is a period of refractoriness, you cannot be contracting just not like fibrillate, you know. It contracts and then it relaxes. In that moment, normally enters a refractory period that should not be activated, no? Or if it gets activated because it's an abnormal path, etc., when activates in the moment that supposedly should be refractory, then it looks totally funny, the activation of the heart, and this will cause that aberration. This is an AV nodal rhythm tachycardia. So remember that circuit that I told you that can reactivate again the heart instead of going like that, then another impulse. This one just keeps going like that. Can also happen in the node. I showed you an example in the beginning of it happens in the sinus node, or it can happen in the AV node. Probably also it's quite common. And as you can see, there will be sometimes some deflections here that are probably, for example, you see here a little deflection. That's a big wave embedded there. There is also the other one is can be confusing because it's called AVN of a nodal, but there's also the AV without the N, just atrial reentrant tachycardia that originates in the topic focus on in the atrium. Normally, the stimulus come from the sinus node to the AV node and carries on in this way. Yeah, but in here it starts here the topic with a, for example, atrial premature beat. Then the stimulus comes to the node, and then will carry on like that. But there is an accessory path where the stimulus can also travel. If when this activates the node and the stimulus comes like that and reaches this accessory path and reactivates in this way, and the stimulus keeps going like that and re-entering like that, that is not normal, but normal will be going like that, going again like this. Yeah, that's normal. But if carry on going like that, otherwise re-entering and cause tachycardia, it's called orthodromic. If the stimulus happens that now travels faster in this accessory path, what we call retrograde, and then start activating the ventricle in this way, and now goes in this direction, is what is called antidromic. So now it's going the other way around. Yeah. So there are differences on the ECG on those ones. But for example, atrial premature ventricular beat here, and suddenly start this complete entrant tachycardia there. Yeah. There's another example of orthodromic. This is antidromic. There's a bit different, so I won't go into the details on that. This is AVNRT. I just wanted to tell you about the mechanism. There's another one. This is quite different. Let's not go into those details. There can be junctional premature complexes. For example, here there is this one, there is this normal, but suddenly there is one complex here. It's not too wide, doesn't have a P wave, and occurs a little bit earlier. So it's a junctional premature complex. Yeah. Here's a junctional escape rhythm. There is no, for example, impulse coming from the sinus node of the atrium. Then suddenly some part of the heart needs to take over the beat. In this case was the junction, and it's a junction escape rhythm. Because this one doesn't occur earlier, no? It's not like a topic focus that suddenly start triggering just like crazy, This one is, okay, no, there is no stimulus, the heart is not beating, no beating, no beating, someone please take over, and then the junction take over, and then there is this beat, then there is a contraction, yeah? So that's the difference between the premature escape and the, yeah? Junction ectopic rhythm. I think I show a similar slide here. This AV dissociation, the P waves are occurring with no synchrony with the QRS complex. But you see the QRS complex is junctional and with narrow. There is also the pre-excitation syndromes. It's a lot of names, but you don't need to remember. Just enjoy. Long Gannon, Levine. Later you say, what was that? What was it? Like, I told you, you're watching Tenet, Memento, all those Inception movies. So there's rapid AV conduction here. You see there's a short PR. Suddenly the PR is very short because suddenly the conduction is very fast between the atrium and the ventricle. There's not like a little bit delay. Yeah. You have heard of the word Parkinson-White syndrome, has got pre-excitation. So there is another accessory pathway that also causes this activation again on the ventricles, and sometimes the two contractions through the normal pathway and the other one fuse, and they form this like delta wave. So it's characteristic. This is another example. I'm not going to go into the details, but you can see these delta waves there. So it's a little bit wider, but there is a notch on the R wave in the beginning. Yeah? This is just another example. Just skip it away. I already showed you this slide, but it's also to show this premature atrial beat. Is the B wave, the QRS, and suddenly that triggers, because there is a reentrant pathway, triggers is now tachycardia, no? And it's AV reentrant tachycardia. I show you, remember the slide with the heart and how it start moving. The orthodromic, we already talked about it. Antidromic. This is another word, Parkinson-White. But this is quite specialized, so because, but it's just, you see, it's not normal. So, for example, this one just also, there's atrial fibrillation. There's no P waves. But this one is wide QRS complex. It has one left on the right morphology, but it's quite irregular because there is a rapid activation through this called Mayhem accessory path or fiber. Can be atrial flutter, so now it looks more regular, but it's the same. Activates through this pathway and has got this aberrant morphology. There is another participation with ABF. The morphology keeps changing because sometimes the conduction is through the normal AV node and sometimes through the accessory pathway. Pacemakers. So I think we are probably this not many. I think this is before the last topic. Yeah, there is one, this one, and then another one. So we are probably a few minutes to complete. I think we will finish on time. Okay, many people have atrial pacemakers. So why is it important? Because you can identify something and, the patient's a pacemaker. You can identify that the patient is symptomatic, has a pacemaker, or maybe you don't see the pacemaker spike, so you need to flag to the doctors, and that could be probably the reason why, because the pacemaker is not working. No? Then, for example, this atrial pacing, you can see here, there is this kind of a spike here. Normally the P wave doesn't have this deflection, yeah? And it occurs regularly, so that's the spike. Then the spike comes, the atrial contraction happens, so the P wave, and the QRS. So that's why it's called atrial pacing. This is a ventricular pacemaker. So the spike happens just before the QRS. So probably there are no P's, or the P's are not conducted. So then it's located in the ventricle, spikes and contracts. Yeah. Sometimes this does not need to contract all the time. No, if there is a normal QRS, probably it doesn't contract. No, just wait until now. There is sometimes they can sense the normal QRS, so it doesn't contract, and then just wait. It's time, and then so that's why you can see the difference in the space here, because in here there was one, but only there was a normal QRS, so the heart did the job, so I don't need to shoot. Yeah. So now is the time. Then I fire. Yeah. This one is dual chamber, so there is one spike in the atrium and one spike in the ventricles, and it's sequential. So fires first, contract, then fires, and they're going to contract the ventricles. Depending on what is the pathology, the electrophysiological studies, which the specialists, cardiologists know all that, they can decide what is the best type of pacemaker for the patient. Yeah. But it's important also to know, but you say, oh, I don't know what is this, maybe there's something bad going on. It's actually just a pacemaker. So that's why it's important you know this. This is also, it's a dual pacemaker, but it's here, firing in the ventricle there. Biventricular pacing here, there is in both ventricles, there is a firing in each ventricle. Yeah? That's why you see two spikes there. They can be also pacing on the his bundle, and that leads to a more normal appearance of the subsequent QRS complex, similar to this case. One of the problems could be that the pacemaker is not sensing, so meaning that for example, here there is a spike and spike and spike, yeah? But here there is a QRS complex, and suddenly these keep firing at regular intervals, even that there was a QRS complex. So meaning that it's not that the pacemaker is not firing, so it's firing, it's working on that aspect, but the sensing of the pacemaker is not working. So it's not detecting the normal, yeah? And that can lead to some problems as well. So it's important to identify. And it's known because if this is seen as a QRS complex, so the next spike probably should be around here, no? But the fact that this early means that it's acting autonomously. Yeah? So this is the last chapter, other diagnosis. A couple of them already mentioned them, but it can be low voltage. So as you can see now, there's no nice progression. So all the complexes look very tiny. Could be because there is amyloidosis, so there is fibrosis sort of the heart. Severe hypothyroidism, so meaning the heart just contracts very sluggish. Precordial effusion that doesn't allow the heart to really contract nicely. Electrical alternance, meaning some complexes have more voltage than others. Also, can be seen by many things, but also cardiac tamponade. For example, here is also alternance there, and that can sometimes trigger fibrillation. Early transition, so like suddenly the R start appearing earlier, being tolerated from B2. This can happen after MI, also the opposite, that poor progression, that the R waves are not really going up, yeah, you can see. They're very shy, so also MI can cause that. Digitalis effect, because bradycardia can cause this concave depressed ST. It's different from the ST from ischemia. Remember, more like that. This goes down like that, Remember, this one is like that. Hyperkalemia can cause these peak T waves. The U waves of hypokalemia that I already mentioned, remember? Yeah. Hypocalcemia can cause this prolonged QT. Hypercalcemia, the opposite, so more calcium doesn't allow the heart to contract more, so that's why it's shorter. Dextrocardia can cause kind of reverse progression of the R waves. No, for example, this is the normally you expect that it's small and it start grow, the R start going up and then down. No, but here it start from it's larger here. So because the heart is in this side, so if you are, the heart is on the left side and you put the leads on the left side, so you're going to probably see the opposite. Yeah? Hypothermia. Typically you won't see this, it's very difficult you see hypothermic patient at that center, no? But you can see an emergency, say an old lady that fell at home and was overnight on the floor, maybe suddenly can have this, and it's just because with the low temperature, every conduction in the heart is slowed down. So in a way, everything is like, it takes longer, and there is this funny wave here, so the conduction is a bit also funny, and so that's why. And this wave is called, secondary wave there is called J or Osborne wave. Tremor artifact is important. I think this is very common. No? Sometimes the patient moves a little bit, and then when you know the patient moves, you repeat the ECG. It's very difficult. No? Sometimes you will be worried of this is what. No, what do you think this could be? If it's not tremor, what this could be? It resembles probably a ventricular fibrillation or something like that. No, so. If you don't know, then you will be worried about the ventricular fibrillation. Probably the patient wouldn't be conscious, no. But or you might, or maybe say, maybe it's a tachycardia, ventricular tachycardia, or whatever. So it's difficult. You have to solve the points, etc. But one way to know is usually the patient has got tremor or is moving because the patient moves. No? But also, if the patient has some essential tremor or etc. Typically, what is going to be more shaky on this ECG is the limb leads. Remember, you have the limb leads and you have the precordial. So usually it's not like the chest moves and the rest not. It's mainly the limbs. So those tremor changes will appear more on the limbs. So that's one of the ways you can see. The O doesn't look so bad in the precordial and then look bad in the limb leads. Remember, the same beat, this same beat here is the same beat here. And suddenly you see in the limb leads, this one looks like that, and this one in the precordial looks normal. So I think it's probably just slightly an artifact. Yeah. So that's one of the ways you can. Also, this one can be many things, but typically you can put the right on the left, and then you can see how funny image the axis is different, etc. So this one probably will take a little more of noise of how the normal looks and say, oh, I don't know what is that, and then just by exclusion you can say, oh, maybe it's because the lymph was on the wrong way if you don't realize, yeah. But sometimes you can see it as an ECG change, and then you will be worried. So just always be careful on how you place the leads correctly. Another, we already commented about this, the fusion and capture beats. The fusion, just the supraventricular stimulus and beat kind of joins the ventricular beat or energy, electrical activity, and create one fusion beat. And the capture beat is suddenly nothing is going on, and then and something just take over, and allows the heart to beat. Yeah. There is something fun, just say, called echo beat. Yes, is simply this is there is a premature ventricular beat that will be probably this one. So occurs earlier. There is a premature ventricular beat, so ventricular morphology, but this premature beat is followed by a P wave. So what happens is the atrium, so the sinus node then activate the atrium, and then the impulse AV node, and then the ventricle. Yeah. So my atrium ventricle. So this one, the premature beat, what it does retrogradely goes back and activates the atrium, then causes the atrium contraction. Yeah, normally it should be this way, and then again this way, again, not like that, no? Just this direction, then the next beat, yeah. So then that happens, activates backwards the atrium contracts, and the atrium now produces a new beat. So that's why it's echo beat. So like it goes, the stimulus, the same stimulus goes here and suddenly goes backwards, and the same stimulus causes contraction and cause a new beat. So that was an echo beat. The same, not a second beat, it's the same. That's why it's called echo beat. Yeah? So, oops, always press that. So, ventricular contraction retrogradely activates the atrium. Is the same firing. The atrium contracts, and the atrium creates this complex that is also different from this one. Yeah. So that's the echo beat. Just by collateral activation, sort of. But I just put that because it's quite interesting. So, as I told you, probably there will be other lectures of emergencies, etc. But something very basic is what to do when you identify ECG changes, no? Even you don't know the diagnosis, what I want you to know is like there are changes from the previous one to that one, or there are abnormalities there that just you know that is not normal in an ECG. So then you flag to the doctor, no? And then obviously symptoms that the patient can have, typically you can have many symptoms, but typically what are the patient feel dizzy, the patient can have some chest pain with all this sort of diagnosis, or feel short of breath, no? Or presyncope or collapse or things like that. No? But by symptoms, the patient start feeling like that, then you need to flag, and maybe you should probably do an ECG, yeah? But once you do the ECG, you see some changes, it's important to know, is the patient hemodynamically stable? You need to take the vitals, no? And then see how's the blood pressure, is oxygenating well, is bradycardia, tachycardia, etc., no? And then the second important thing is that you need to know that the patient can deteriorate, no? So like mine, suddenly you find, oh, patient feels funny, feels a little bit dizzy, and you identify some premature ventricular beats. So I think two things are bad, no? The ventricular beats can later lead to a worse ventricular tachycardia, fibrillation, etc. So it's probably the time to probably call an ambulance, and especially if patient is symptomatic, you have this, and if it's a new change. So you need to always bear in mind that the patient even is talking to you now, the next second might collapse. So it's true. So I always tell my nurses. So when you find a patient that is like that, immediately call the ambulance, and then you start, arranging all the administrative. So the best for the patient and for you is that the patient leaves the center as soon as possible, because he's better off there, and you don't want to be resuscitating in a patient in the center, because how stressful for everyone, for you, for the family if it's there, for the other patients, and also the facilities are not as convenient for resuscitation than if the patient is already on the ambulance or is in A&E, no? So for that reason, it's always, when there is something that doesn't look okay, or is different, or new symptoms or new ECG changes, it's probably better to play safe and send the patient or ambulance as soon as possible, no? Don't delay your administratives or thinking of call the doctor first. You call ambulance first and then call the doctor. Also, what if the doctor is, doing exercise or taking shower or things like that. So, and those 5 minutes, probably ambulance is already there, yeah? Obviously, as I tell you, you could have learned something from this lecture or from reviewing the notes. So if you want to study further this subject on your own, it's definitely much better that you can tell the doctor, oh, doctor, I think he's got an atrial fibrillation, or I see some ST elevations. Doesn't matter that you know, but you probably, the more information you can gather, the more information you can gather to the doctor. Or you say, oh, I think the ECG looks a bit funny. Okay, send me the ECG, and then okay, you wait for probably say, I think as well as the elevations, the ECG, so then the doctor tell you, okay, just call ambulance, and then someone else start talking to me, it's for a different approach, yeah? So, if you want to study more, I don't know if NKF give you access to up-to-date, NKF? No, okay. So basically, I take all these pictures from up-to-date. They are quite nice. There are many sources on the internet, and I study some cases in med mastery. Probably you have seen in Facebook now they are doing all this med mastery. I see a lot in Instagram, or maybe because I was studying about ECG, suddenly started appearing in my Facebook. Whatever you search, start appearing in your Facebook. So be careful what you search. And then, so I studied some cases. So I actually found quite useful this. It's quite fun, this med mastery. But you have access today. Otherwise, you have the slides. That is basically all the pictures from there. And I hope that you enjoy. I hope it was useful. You might have not gathered everything that happened, but at least compared to when you started, probably at least now the guy has got a weapon. Before they didn't have the weapon. I hope that you are more equipped or armed than before to deal with ECGs. And just a couple of announcements. Obviously, this guy is me. I published an ebook. I think last month, on kidney disease, mainly for patients and caregivers, but obviously also can be useful for you if you want to know more about some of the topics of kidney disease. I can just show you, if I press here, remote. Again. So just show you how it looks. We just 20 seconds click. So. These are all the topics so far. Later, I probably plan to do others. There's probably a couple of pages per topic. It's more on a kind of question and answer basis. So you wonder, how can I travel if I have a kidney transplant or on dialysis? There is a question on that, and then you can browse it, etc. So, but it can. An announcement is the NKF director. Who is the NKF director? So told me that it was very good. So then you should probably read it. Yeah. So it's recommended by Dr. Baron. Yeah? And you can in my website. This is the link. So you just go to my website, but there is the link here. You can download the data for you to register with your email. And also, I have a Facebook group that I've been, because of the Christmas and all this, have a presentation tomorrow and other things I have to do. So I've been a little quiet for the last couple of weeks. But I do I used to do a weekly video there on topics. It's kind of basically the ebook is kind of what I did in my videos. So, because of the COVID, I started doing these videos to try to keep the patients updated, and then I decided to kind of do the ebook based on the videos. So now I would like to do it concurrently. So you can also join this group. It's a private group, but you just need to register and then see me talking about this. And it's live and it's interactive. Yeah, it can help. Some of the nurses say it's good as well. Thank you. So if you have any questions, so now I'll be happy to address it. Yeah.
In ECG, the hypothermia and in LBD, there's like M pattern in the QRS complex. So how we can differentiate is a hypothermia or LBD?
LBV, left bundle branch block?
Yes.
Okay, so basically the hypothermia, you will tell me, the vital signs will tell you, no? Like okay. the patient is, how to say, maybe the temperature is 30 degrees, etc. No? And let's say if you see it in a patient that probably is normal thermic, so you will think probably more like that. But also there are other features, no? Those waves happen more into certain more widespread, while the double rise left on the rise pattern, some leads look a little bit different than others, and it's kind of typical. But also the history is very important. We just saw ECGs, but the history is very important. Let's say you have a young guy was just doing exercise and suddenly start feeling dizzy, palpitations, etc. Most likely that will tell you it's not an MI, probably it's just one of those re-entrant tachycardias, ventricular tachycardia, etc. Guy with a flu, has got chest pain, start with some chest pain, it's worse when you start breathing and etc. So could be indeed myocarditis, but you see ST elevations, probably is most likely a pericarditis, Old man with 2 MIs, only chest pain, radiating, and then you see ST, and then you probably is more likely an MI. So the history is very important, but for that you will have a hypothermic patient, and then the ECG show this, but most likely. But indeed, you can have a hypothermic, the conduction start getting funny, if they have already ischemia, etc. Suddenly you can have a limp on the branch block, or they can have even can have an evolving MI, so you can have both, but the history is very important to tell you. The ECG is a superb tool, but has to be taken together with the history, that's one of the things, yeah. Is that okay?
Then in atrial fibrillation, we can see so many P waves, because it's fibrillating, so we can see so many P waves, and the heart rate sometimes very irregular. Other than that, any other characteristic can be seen in the ECG?
For which?
Atrial fibrillation, AF.
Atrial fibrillation, so the rhythm is irregular. Yes. You don't see so much, you don't see P waves.
Yes. Sometimes you can see so many P waves, right? Because it's fibrillating.
Okay, but the thing is, you don't see really P waves. When you see a lot of P waves, probably it's a flutter. The sawtooth is the flutter. You see those P waves, that's the flutter, and typically it's more regular. In the atrial fibrillation, the characteristic is you don't see P waves, so there is no P waves. Indeed, the baseline might be a little bit funky, but you don't see proper P waves. No, the proper P waves just is indeed could be there. Deflection could be, but you see something nicely. So that's one of the characteristics of atrial fibrillation. There's no P waves, and it's irregular. But sometimes I know it's difficult. No, you are not sure if there are P waves or not, and this is more of experience. But by right, you should not see. If you allow me, maybe I can just show you. Okay, you see atrial. This one no, but there's another one there. I don't remember. I think I missed about it. Okay. For example, this one is atrial flutter. This is the atrial flutter contractions that you can say P waves, but it's the atrial contraction, the atrial flutter, and this is different from the other one that is the A capital F. Unfortunately, it's not here. I don't remember where. Okay, yeah, I just tell you. So in the other one, you will see that probably there is no P wave, and typically it's irregular. So like, for example, this will be one ocular complex, another one, and there is no P wave. Sometimes there's fluctuation. Yeah, but it looks a little bit different. Unfortunately, the AF is the atrial flutter is so characteristic that but the atrial fibrillation is sometimes difficult. It's difficult to identify when there is aberrant conduction and the wide complexes. There are wide QRS complexes, so you now don't know if it is atrial, atrial fibrillation or some degree of ventricular tachycardia, etc. So it requires more experience, but typically. In that case, more confusing. But if it is just you're not sure UCP, but one characteristic is like it's irregular, then it would be an AF. You might see P waves, and it's irregular. Could be a sinus arrhythmia. No, remember the one with the when you inspire or Any other thing? Any other question? Oh, yeah.
Actually, previously we have one patient. The ECG shows PVC, premature ventricular contraction. Yeah, but when we do that map, use the machine check the pulse, it's 30-40. But when we do ECG, it's 80-60. Then the doctor say, okay, can continue dialysis. So what's the reason why the pulse cannot pick up by the map or machine maker?
Okay, so the heart rate was 80.
ECG shows 80 plus. Yeah.
Okay, and the 40 was where?
On our dialysis machine BP check.
Okay, so obviously that one, I'm not sure how is the accuracy of the machine to detect that, but I will trust that probably the ECG is better on that. As you sometimes the blood pressure is not the same when you do it manually than when you do it in an electronic machine, especially if the rhythm is a little bit funky, etc. Might give you these discrepancies, but then I would trust more the ECG. And also, this rhythms is not like the patient might be 1 minute in something. You take the ECG, how long it takes to ECG? Probably a couple of minutes to sometimes 15 minutes to do the whole thing. So maybe the situation already changed, no? So you need to pay into account all those things, but it might be that it's not so accurate taken from the blood pressure or from the machine, yeah. But I'm not sure what is the accuracy of that machine, etc. But I would probably trust more the ECG because the ECG shows you electrical activity. So it's like you can measure also the pulse here. So and then you can see there are going to be always variation. And in a patient that has got probably an arrhythmia, so the variation can be from 5 minutes to 5 minutes earlier, could be maybe a different rate and different things, no? And the patient can have sometimes the complexes, later can have runs of tachycardia, yeah, and so you have to see it, the whole picture. So I don't have a precise answer to that, but these discrepancies can happen because it's different method to read the same thing and probably was read at different times, no? But I would trust the ECG is probably much better, no? Yeah, for that. And then so the doctor told you because the ECG is okay, you can proceed, no? And you proceeded, and the patient went okay, correct?
Yeah, okay.
Yeah. So yes, probably because maybe it's not so accurate because the dialysis machine is not designed to do that. No, the ECG machine is designed to do with electrical activity. It's just like a washing machine that can dries and wash and cooks at the same time. So it's not going to be the best dryer, washing, and cooker. So basically, the same happens. All these features are very nice, but it won't be probably as accurate as good as something that is specific or designed for that. So that's my just educated guess on that. But I think the doctor did right. Check the ECG and then confirm if it's bradycardic, if there are some complexes or any arrhythmia that requires something else. You confirm the heart rate is better, there is nothing major, so the doctor said, proceed, yeah. So I think it was okay. So I think that was an okay, but the discrepancy probably because it's different methods, etc. And could have been at different times now. because not the, you might have done the ECG a little bit later, maybe the situation, clinical situation changed. Maybe it was real that it was 40 and suddenly now it normalized a little bit, no? Anything else?
Sorry.
Yeah.
I ever encountered a same issue many years ago. The doctor asked us to monitor with the at the time we don't have the ECG machine. If we leave it PVC untreated for persistently like that, is it safe to dialysis? Continue the dialysis?
So what was the condition?
I mean, it's the PVC like untreated.
The PVCs.
Yeah, but
Okay.
my patient is asymptomatic. Can we just continue the dialysis? I mean.
Okay, so the thing is like everything has to be taken in the history. There are patients that already have premature ventricular complexes or certain arrhythmias that you already know that they need to continue with dialysis, no? And they probably will be more high dependency or higher risk, etc. But you still need to proceed with the dialysis, no? But let's say if it's a patient that never has that, suddenly starts symptomatic, you do an ECG and you see now new premature ventricular complex or any sort of arrhythmia, then probably that patient might not be safe to dialyze at that moment. You probably need to send to the hospital. Maybe later they do whatever and they know that's his new and there's nothing major to do, but it still remains with occasional complexes and at that risk, or maybe they put a automatic defibrillator or whatever. Then the patient might continue with that, but already we know what is the problem, so it's depending on the clinical scenario and when it's a known patient or it's something new. If it's something new, then you probably need to flag it and investigate and treat. Eventually, you need to still accept the patient and dialyze, and then probably you will need to continue with dialysis despite having that. And there are many patients that have these problems, but simply they are higher risk. But definitely, if it's a patient that you don't know and is symptomatic and you identify this for the first time, probably it's better to err on the safe side and send to the hospital for investigation. Yeah. Any other question? Yeah.
Can I just know for ICDs?
Yeah.
On which like specific abnormal ECG that this patient will have to okay. On this ECG, when you see it, this patient requires ICD straight away.
Okay. But yeah, I'm not a cardiologist, I'm not a physiologist, yeah, so I'm a nephrologist. So, but there's not like a really abnormality like that. So you probably after this, you probably need to do electrophysiological studies and then decide what is the main problem and the best type of, defibrillator, implantable or pacemaker. There are many types. Sometimes depends on what is the abnormality. Could be that there is one single abnormality that maybe one single chamber or needs dual chamber, but typically, if the guy is showing, he's kind of an MI and now she's showing some ventricular tachycardia runs, has a presyncope at home, and it's someone that most likely will need it, no? Someone really shows that the ventricle is quite, easily to treat. So it's a high risk of a ventricular arrhythmia, or people with a complete heart block, etc. You're most likely that this patient will need a pacemaker. But also, you need to take everything into context, because let's say someone has got an MI and maybe has got a second-degree heart block, but sometimes it's temporary and it lasts for a couple of weeks or so, and later recovers. When so probably you don't need to put really a permanent. You might need just to monitor the patient, etc. No, but sometimes yes, complete heart block probably will need it. And let's say you have already, this patient went to ventricular tachycardia, have collapsed because of ventricular fibrillation, etc. So it's most likely that probably you will need to put an implantable defibrillator. No? Also, the level of the heart function depends. No? The lower the ejection fraction, also more chances for arrhythmias. There's higher ischemia, more for arrhythmias. So it has to be everything put into consideration. So it's not like a specific diagnosis needs this type of defibrillator or pacemaker, but definitely the more severe changes, the more impact has got, it has collapsed on that, is most likely to require one of these. And what type, it depends, because there are many types, no? And they are, for pacemakers, there are different types of pacemakers, atrial or ventricular or dual, and also they can sense or they can fire, they can be on demand. Some of them that also, for people who do exercise, they can sense when the people start having more activity and then they trigger faster, like call the heart rate. So it depends on many patient factors. For that, I can tell you probably it's beyond my paycheck to answer properly that question, because at the end of the day, it will be probably sometimes not even the cardiologist, but the electrophysiologist, or it's a cardiologist with a specialty on that, who eventually will decide what is the best. But typically, Emma is already having runs of tachycardia, previous ventricular fibrillation, etc. Most likely is going to need one of those, no? Because the risk is high. But it's not like straight away you just send them for that, you just send them for assessment and they will decide, no, which one is the best and at what point is the best time. But obviously all those things that, if you already have some ventricular contraction, some couplets, some runs of tachycardia, then this patient is quite risky, so it's better to be assessed properly by a cardiologist. And some patients deny also, no, to have these devices, so they just buy the risk, and then you need to live with that. No, simply has to be a high dependency, a high risk patient for collapse on dialysis. Anything else? But typically, it's one of the common paths. No? Either if they have one of these blocks, typically pacemaker, if they have arrhythmias, they will require that. But sometimes depending on the arrhythmia, if your ACE is a supraventricular tachycardia re-entrant, sometimes just this ablation can be done, and then just and the problem is also depending what is the arrhythmia. But some of them goes into this part, into that, but sometimes it has to do with proper analysis, because some patients might have different pathologies and going on. So, yeah. So at the end, electrophysiology studies is important. No? Many of these patients, the ECG is one snapshot, just a few seconds. The next step probably would be, yes, refer to cardiologist, see what the doctor thinks, but then the Holter is one also next best steps, because now 24 hours, or could be 48 hours. The Holter, an echo, and then maybe all together, and then eventually probably physiological studies, and then you can decide now what is the best for the patient. Yeah. Any other question?
Any other question? Yes, that's it. Thanks, Dr. Francisco, for your sharing to us.
Alright, thank you. So I hope it's useful. So for the slides, I will share the PDF. So I email.
Sorry.
Okay. Okay. Great. Okay. So thank you for your attention. So I hope it was not too dense. Well, it was too dense, but.
Yeah.
All right. Thank you.
Thank you.